please. Okay, thank you. Just wanted to provide an acknowledgement of country before we kick off. And as we gather for this meeting, physically dispersed and virtually constructed, let us take a moment to reflect the meaning of place, and doing so recognise the various traditional lands on which we do our business today around Australia. We acknowledge the elders past and emerging of all the land we work and live on, and their ancestral spirits with gratitude and respect. Next slide, please. Okay, let's kick off on our clinical education session. As we all know, this is an open session that people that are in the Triple C program and others are able to join. So before we kick off, a little bit of housekeeping. Please ask questions in the chat. We will have some of the mentors answering some of the questions. We also have at 6:35 a Q&A session, as we have for the last two, where we can answer further questions that may arise during the presentation. Please leave your cameras on. Stay muted until the end of the actual presentation from Mandy. And with no further ado, I'd like to actually hand over to Mandy. Amanda is an alcohol and drug nurse practitioner working in the ACT. Amanda graduated from Sydney University in 2015 as a nurse practitioner and is working as an opioid prescriber, amongst other roles, with a keen interest in microdosing research, management of alcohol and other drug withdrawal, education, and a HCV treatment prescriber. Amanda has attained 2 other master's degrees in alcohol and other drug nursing and mental health nursing. Amanda has been a nurse for over 20 years in both the UK and Australia, with previous specialty training in intensive care nursing. On her days off, Amanda assists on her farm with her husband, delivering equine assisted therapy with 7 gorgeous horses and a boutique egg business with their 70 hens. They have 2 children and live in an idyllic life in the country. Over to you, Mandy Coslet, and thank you for providing this presentation today.
Great, thank you. So we'll go to our next slide. Okay, good evening. Just back first, please. Thank you. So good evening, everyone, and welcome to the next in series of the Triple C program. Tonight's topic is indeed, what's the deal with cannabis? I'm presenting this from the beautiful surrounds of Canberra, although cold and rainy, and I would like to acknowledge the land of the Ngunnawal people, our First Nations people, past, present and emerging, and thank them for the contribution they make to the life of this region. So yes, I am an alcohol and drug nurse practitioner and have been so since I actually qualified in 2015, but got my big break in 2016 early on. And I'm based at the Canberra Hospital, which is our big public hospital here in the ACT. I've been in drug and alcohol for quite some years, at least 17. And previous to this, I was also a specialised in intensive care, where I would commonly see the catastrophic results of misuse of alcohol and drugs, particularly amongst young people. My work now of opioid hepatitis C treatments, managing the inpatient alcohol and outpatient alcohol and drug withdrawal, and undertaking some research. The other big love of my life is education, because we need to teach and train the people who are going to be caring for us. So thank you for inviting me to speak. I hope you enjoy the session. Next, please. Oh, actually, yeah, if we can, oh, sorry. Yeah, if you can stay on that one now, thanks. Lovely. So let's have a chat. Here is an overview of what we will be covering, and hopefully you've also received and refreshed yourself with some of the facts about cannabis in the pre-readings. During my years as an MP, I have talked about cannabis a lot in sessions, and it was never my favourite topic. I don't know about you guys. You probably have a favourite topic, I'm sure you do. But I've actually grown to be really fascinated by cannabis, mainly because so many people do use it for all sorts of reasons. Cannabis was always seemingly so accepted in Australia, unlike where I came from, the UK, back in the 90s. Drugs were just not talked about. I emigrated in '94, and my first experience was being offered a cone in a nightclub as soon as I reached the Australian shores. Such was my naivety, I wondered, why would I be offered an ice cream in the middle of a nightclub? And I politely declined their very kind welcome. So let's talk about what cannabis is, where in your brain and body does it affect, and how does it do that? We can talk about some stats, of course. We all want to know that, and the effects of using cannabis. Additionally, let's talk about some treatments. Consider just how dangerous or not is cannabis for you. And please note, while we'll touch briefly on medicinal cannabis, it's not a focus for tonight. This may be a topic for the future, but really that's in the sphere of neurology and pain management rather than alcohol and drug. However, we do get our fair share of inquiries from the general public of how to secure their next medicinal cannabis script. Next, please. Okay, so obtaining credible data about cannabis is very important. The National Cannabis Prevention and Information Centre, or NCPIC, used to provide a wealth of information and training to both clients and health professionals. This service was unfortunately disbanded in 2016 due to funding, and a local organisation called Cannabis Support, not financially resourced, but took its place and its documents under licence from University of New South Wales. Although they haven't got the resources to update the material, they still make a sterling effort in trying to keep up to date with what's happening in the cannabis world. Other source material can be derived from credible sources such as ADF and NDARC. In the resource section of this talk, I'll talk a little bit more about that. So cannabis is the name applied to products derived from the cannabis plant sativa. You'll notice that there is another plant called indica. I'm talking mainly about sativa this evening. Marijuana does refer to the buds and flowers of the plant, depending on what you read, and is a term widely used overseas. Research data suggests the use of cannabis as far back as the 3rd millennium, so it has been around for a very long time. The main active ingredient in cannabis is, wait for it, the tongue twister, that is delta-9 tetrahydrocannabinol, or commonly known as THC. Cannabis also contains the non-psychoactive cannabidiol, or CBD. This is also at times a difficult word to pronounce, so forgive me if I do mispronounce it at times. This is currently used as a medicinal agent. Next, please. In this slide, we look at how people use cannabis. So hashish, or hash, is the dried resin from the cannabis plant and can be smoked or added to foods and eaten. Hash oil is extracted from hashish and is the most potent form and can be smoked, usually through a glass pipe, also known as a dab rig. I don't know if anybody knew about that. Dabs or dabbing are the names for the use of concentrated butane hash oil, or otherwise known as BHO. It's a relatively new method of administering and ingesting cannabis that involves the inhalation of highly concentrated THC. This concentrated form is produced through a chemical process using butane oil. The dab is the amount, usually no bigger than a grain of rice, and dabbing is the process of smoking or vaping. Edibles are foods that contain cannabis, such as hash, dope cookies, and cakes. These products can take 1 to 3 hours to take effect, and it can be difficult to regulate the amount of cannabis consumed. So people might keep on eating because they're not getting the immediate effects. Next, please. Medicinal cannabis are forms of cannabis that have been approved by the Therapeutic Goods Administration, TGA, and typically come in the form of oral solutions or capsules that contain carefully controlled concentrations of THC and CBD. Hemp is a term used to describe any cannabis plant that is cultivated for fibre, so for example, ropes or for their seeds, and it will generally contain very low levels of THC, but potentially high CBD. Next, please. I love this slide. I love this bong here. So in this slide, the main ways of using cannabis are explained. It's really quite interesting when I do talks about how many people are actually quite naive in how drugs are actually used. And so it's always interesting to show pictures like this. I also take some homemade bongs as well, because plastic bottles are very commonly used. Not good for people, but commonly used. So you can actually see here, so cannabis generally is either smoked via joints or bongs. So if you look at the circle part, that's what we call the cone bit, okay? Typical prices of cannabis can range from 1 gram, and this can sometimes be referred to as a stick, at a cost of $10 to $15, upwards to 28 grams, which can be anything from $300 plus. When we assess clients, we may ask how many cones they may smoke each day. I consider 5 or less to be low use, and anything upwards of 20 to 60 may be considered moderate to very high use. Can you imagine finding a time in the day to smoke 60 cones or more? But maybe you've had that experience of clients who actually do smoke that much. And we can certainly talk about how they then may present. Using water pipes is a very common way of smoking, and the paraphernalia can easily be obtained from tobacconist shops as long as the devices are not listed as therapeutic items. Next, please. So synthetic cannabinoids, or the correct term of which is new psychoactive substances, are powdered chemicals that are usually sprayed onto herbs and sold in colourful branded packets. The chemicals vary from batch to batch, so different packets can look different to other ones, even with the same name. I guess the lure of the NPS substances or the synthetic cannabis is that they're often sold as a legal alternative to cannabis and claim to have similar effects. They're often sold as herbal smoking blends with different names, such as K2, spice, and chronic. The truth is, the herbs contained herein are not known and can have serious hallucinogenic properties and may interact with other medication, for example, antidepressants. They may not have any cannabis products at all in them, and they've been sold online since at least 2004. When other psychiatric medications are used, there is a mix of inhibiting and upregulation of neurotransmitters, which can further affect mood. And people can get what's called negative symptoms. And these can be described as a lessening or absence of a normal behaviour, for example, withdrawal from people or not talking. There have been cases in Australia of individuals taking NPSs and jumping off balconies. Next slide, please. So let's have a look at the stats. The good old survey of the National Drug and Strategy Household Survey that's taken every 3 years. The information on this slide is actually from the 2019 survey. It's usually reported in April of the following year, but because of the pandemic, this was delayed by a few months. So it was released in 2020, but and it's still a reasonable snapshot of just over 22,000 Australians over the age of 14, asking them about their alcohol and drug use. As with any statistics, it's always remember the survey is a self-report, and other alcohol and drug data should be balanced with other credible sources too. I do believe the conversation around cannabis has changed, particularly since 2020, and these in part are due to further changes in legislation. I only concentrate on ACT legislation, and of course, as you know, ACT has got the most liberal laws around cannabis of anywhere, or that's the perception. But also the conversation towards using TGA-approved medicinal cannabis, which some NPs can prescribe because it's within their scope. Cannabis remains an illicit substance, but its use has increased from 10.4 to 11.6%, as in that slide. But further decriminalisation has shifted users towards health rather than the justice system. I urge you to check your state and territory laws around cannabis. I'm concentrating on the ACT, and the ACT health pages surmise this very nicely. So, for example, it's illegal to smoke cannabis in public. It's also illegal to gift or sell to a friend. It is, however, decriminalised to have 2 plants or 50 grams of cannabis for personal use at your home. You could grow those 2 plants in your home, but it is illegal to buy the seeds. So, I wonder how you do that. It's a bit like the chicken and the egg, I think. If you were on the bus and the police stopped you and found cannabis on your person, you may get a warning or a fine. Or if you're found to be cultivating or trafficking, you could get a prison sentence. So it's still a little bit grey. Next, please. So bear with me when we talk about how cannabis affects the brain, because it always involves a receptor. So in this slide, we explore how cannabis affects the brain, and the name, and I think it's on that slide there, about the endocannabinoid system. So we have this system internally within our body, and it's derived from the fact that bodies of complex animals hold natural chemicals that resemble the activity of THC. This system is actually essential. It's responsible for regulating so many of our bodily functions. It warns and protects our bodies when aid is needed. For example, with appetite, metabolism, pain, and sleep, just to say a few. Cannabis is often associated with intoxicating effects, being its most abundant element, better known as THC. However, CBD does not cause intoxication. The substance does, however, impact the central nervous system and the body more broadly. And we're beginning to understand how CBD in particular affects the brain and body. Scientists are scratching the surface of potential ways that CBD may be used for health and wellness, and so cannot yet fully explain how the substance may confer those benefits. However, as more and more evidence for the advantages of using CBD accumulates, the government has become more open to CBD use and more committed to understanding how CBD may improve health or quality of life. So how does CBD, for example, work in the body, you may ask? Well, CBD impacts our bodies largely by binding to proteins or to the receptors that are located in the surface on our cells, therefore initiating certain physiological responses. The nervous system contains the cannabinoid receptors CB1 and CB2. However, unlike THC, which interacts extensively with those receptors, CBD does not appear to bind strongly. It appears to achieve its effects by binding to other types of receptors, such as serotonin, known to influence things like pain, mood, and sleep. And when it comes to the specifics of how CBD achieves its effects, the research surrounding epilepsy provides us the most valuable information, given that it has been investigated to the point where CBD drugs are available for treatment. A key finding in the case of epilepsy is the impact of CBD on nerve cell sodium channels, the movement of sodium in and out, which is often abnormal in epilepsy and causes the brain cells to fire inappropriately. CBD has been found to inhibit this problematic flow of sodium, reducing and minimizing seizures, which is fabulous. However, another angle, Vaughan in 2021, looked at the impact of cannabis on concurrent antidepressant treatment, such as Zoloft or Lexapro, commonly used. And as you may be aware, these are selective serotonin reuptake inhibitors, or SSRIs, and found there was clear evidence of drug-to-drug interactions. So people using cannabis and using antidepressants found that there was elevated plasma levels of those medications through pharmacokinetic activity, and this led to side effects such as increased sedation. Remember, serotonin influences sleep. Next, please. So just keep an eye on the eye. We'll be talking about that in a second. So on this slide, cannabis users have shown decreased reactivity to dopamine, suggesting a possible link to a dampening down of the reward system of the brain and an increase in negative emotion. Cannabis users can develop tolerance to the effects of THC, and the mechanisms that create this are thought to involve changes in the cannabinoid receptor function. Have you ever wondered why people get the munchies? Hopefully that's a term that you've heard. This is a term used of increased appetite, and specifically people use cannabis for this very reason alone. Cannabinoids like THC mimic that endocannabinoid system and bind themselves to the receptor sites. Leptin is a hormone released by the fat cells that tells your body to stop eating, specifically when you've had enough. This is effectively overridden when cannabis is used, and THC also counteracts another transmitter called anandamide. THC binds itself to the same receptors, increasing appetite. Just with that eye there, you may see the redness and the bloodshot eyes, which is very common for some people who use cannabis, and it's synonymous with the term being stoned. It occurs due to the micro blood vessel bleeds that can occur because cannabis also dilates your blood vessels. Next, please. So there is a strong correlation between people using cannabis and spinning or mulling with tobacco. Tobacco helps to mellow the cannabis. So a nicotine use disorder is also common, even if the person says they do not smoke tailored cigarettes or even rolled cigarettes. Be aware, cannabis smoke also emits carbon monoxide, as it is a burning organic material, being plant-based. Carbon monoxide is the gas that binds strongly to a red blood cell, reduces the oxygen carrying capacity, so you make more red blood cells and you get that thick, sticky blood that leads to a risk of strokes and heart attacks. There's a vulnerability of people who have a comorbidity of mental health illness, that if exposed to cannabis, they may develop a psychosis. The neurobiological process is still very poorly understood in this case, and there have been suggested data links to something called the AKT1 gene, which signals changes with dopamine and upregulation, which may affect the likelihood of a psychosis developing. This particular gene has been identified as being the instructor to the body of how to make protein in the cells, and is attached to the chromosome number 14. Next, please. Hope you're still with us. So on this slide, there's a good summary of cannabis use as a disorder. The presence of at least 2 of the 11 criteria in a 12-month period can lead to a differential diagnosis of mild cannabis use disorder. The more criteria, the more severity of the disorder. When we discuss the disorders, we explore the loss of control a person may have over their drug use that is symptomatic of neuroadaptation occurring. And you can see on that slide, there are the 11 criteria. Next, please. So through assessment, we can pick apart some of the DSM criteria and how affected a client might be by their drug use. These are all good themes on this slide about what to ask the client about. We concentrate on how the drug affects function. We ask about, is there a loss of control over the drug being used and has it taken over their lives? It's important to see if any polydrug use is occurring, as cannabis is a depressant drug on the central nervous system, and taken with other depressants, alcohol, for example, opioids, for example, could lead to oversedation. It's also an opportunity to explore sexual health and risks of bloodborne diseases such as hepatitis C. Next, please. So none of the withdrawal symptoms that you can see on this slide are particularly life-threatening, but they can be very uncomfortable and can increase the risk of relapse. Most clients that I see and deal with tend to find insomnia one of the main challenges. Next, please. There are the information on this slide are very common sense approaches. The choice between in and outpatient services depend on what the client wants and what is available in their area. A lot of people use cannabis and don't seek any support for it because they use it for pain, or they might use it for sleep or relaxation and don't see it as a particular issue. We do actually think about the other effects of cannabis, so such as the smoking component and what that does with the lungs, and the throat and the mouth. So there's just other things to, that people might want to cease their cannabis use because of those reasons. So the choice of, is it an in or an outpatient service, really depends on what is actually available. Outpatient services may enable clients to get on with life without restrictions, such as continuing to smoke tobacco, for example, that might not be permitted in an inpatient setting. However, most inpatient settings can enable a wraparound basic caregiving service, including sleep, nutrition, other supportive therapies like CBT. As explained in this slide, CBT can be very useful in identifying unhelpful thoughts, for example, and challenging those thoughts. It also works on strategies for people. Next, please. Medications that may be used do include benzodiazepines, such as diazepam, as an anti-anxiolytic, and of course, nicotine replacement, if clients were spinning tobacco with their cannabis and wish to cease all drugs. I will talk a little bit more about medications in a moment. Additionally, and although not much time to discuss here, be mindful about managing women who are pregnant. An inpatient admission might be a better alternative for motivated women wanting to cease cannabis use in pregnancy, as symptoms can be managed and medical support available if there are complications. Women may experience hyperemesis, so excessive vomiting, with cannabis use in pregnancy. The exact physiological reason for this remains not completely understood, but again, on-hand medical support can be available. Cannabis does also pass through breast milk, so educating women about expressing and discarding is a very useful exercise as well. Next, please. So on this slide, there is further pharmacological support that can be used. And this is from the New South Wales Alcohol and Drug Clinical Guidelines, which are a little bit on the old side, 2008, but are actually being updated. This is similar to many other state and territory alcohol and drug guidelines about what is available. The use of antidepressants can be useful in the face of withdrawal in increasing dopamine levels. However, as most detox units, for example, ours is only 7 days, the use of antidepressants are for a longer term use and are better managed in the community. But certainly the medications that you see on this slide are all of the things that we would help people with, particularly working on things like sleep hygiene as well. A lot of it's all about just comfort for patients or clients rather, who are going through this withdrawal. Next, please. I would like to just touch on the registered medical grade cannabis medications, of which I thought there was only one, being Sativex. This was data that I actually originally obtained from the NPS, which was the National Prescribing Service. However, through researching for this talk this evening, the University of Sydney also have information on the second medication used in the treatment of seizure control called Epidiolex. That's the one, which is a registered product also. There are other unregistered products that need special license to administer through the TGA, and some of those that I do not have the names of. In Sativex, the active ingredients is actually called nabiximols, which is a cannabis extract and part of the cannabinoid group. Whilst it was seen as a possible replacement medication, similar to opioid maintenance replacement treatment for opioids, and has been used in trial for many, many years, the notion of this being a replacement medication has not come to fruition. It is, however, now being used to improve symptoms related to other medical conditions, for example, with multiple sclerosis related to muscle stiffness, where other medicines have not worked, which is quite interesting. Please. So on this slide, we've got the resources that will assist you as a nurse practitioner to help your clients. And as I said, I've already mentioned the clinical practice guidelines, but also we do have cannabis withdrawal monitoring scales, which can vary from state to state. There's no magic number. It's just if you start to see a little bit of a pattern of increasing symptoms such as anxiety, insomnia, then you might want to help someone maybe with a little bit of Valium just to help with that. There are a number of other resources that people can also get self-help with. Cannabis Support, as I said, is one of those, but also the ADF have a number of resources as well and information. There are some groups as well. In the ACT, for example, we've got a weed group, and that's a peer supported group that helps people as well. And in conclusion, a number of studies and research papers have explored cannabis over time with an emerging evidence of its medicinal usefulness literally exploding onto our platforms, but its use remains somewhat controversial and has maybe led us to letting our guard down a little bit with cannabis and overlooking seemingly the harmlessness of it too. Time will tell, but please don't underestimate its use, either particularly for people with mental health vulnerabilities. Next, please. Happy to share these slides if you would like them. And thanks for listening, everybody.
Thank you very much, Mandy. You've certainly taken